What I'm going to do today is talk about the blood culture pathway and how improvements in the pathway can actually improve patient outcomes, also actually even improve infection control practices. So I'm going to go through the talk on briefly review what the blood culture pathway is, and then look at the pre-analytical phase, analytical phase, and post-analytical phase. So we're going to look at those areas, see where improvements can be done, where challenges are, and how really this affects patient safety and antibiotic stewardship. So the blood culture pathway, there's a pre-analytical phase, which we first need the clinicians to identify the patient is actually septic. That's the first important thing, because if they don't do that, then they can't do the blood cultures. So identify the patient, that the patient is septic. And then sample collection. So having done that, the sample being collected needs to be to make sure that the patient and the sample labeling are the same, okay? And then the sample has to be transported to the lab in an appropriate manner. And at the end of that, the sample has to be incubated. So that's the pre-analytical phase. The analytical phase happens in the lab, and that is identification of the organism, and then testing for further testing to see what the sensitivities are. The post-analytical phase is when the results are available, the microbiologists will have to communicate with the caring teams to make sure the patients are on the right antibiotics, and also whether patients need to change antibiotics or even stop antibiotics. And then making sure that the decisions are being done in a timely manner. So it's no use having the result, waiting 5 hours before you act on it. It should be acted on quite quickly. So looking at pre-analytical phase, so we identify the patient. Patient is septic. And then the clinician has to take a blood culture. We very rarely get this problem where either the sample has got the wrong patient or unlabeled sample. So if it's unlabeled, we just have to reject it. But sometimes there are two sources of information on the bottle. One, the name is different, and the number of the patient is different. So we have to resolve that, who's the patient's blood it is. But that happens quite rarely, okay? Then the volumes of blood in the blood culture bottle is very important. So sometimes they may not fill them correctly, which is not good. And also the maximum collection of blood culture, we need 2 pairs, so that's 4 bottles. Most places they're still doing 2 pairs, 1 pair, so 2 bottles. And then with the we have in the UK and many places as well, networks. So with networks, the lab is central, and some of the hospitals might be far. And transportation therefore matters, because if the transportation is not good, the samples are delayed. And depending on the distance, you might consider temperature control during transportation. So again, those things have got to be considered. So we have challenges in the pre-analytical phase. Okay. If the patient's, if the sepsis identification is late, then poor outcomes for patients. So for every 1 hour delay in a treatment, there's about a 7% increase in mortality. And if the patient is actually in septic shock, that can go up to 35%. So the clinician has to be very aware and make the diagnosis. We have some cases where, for instance, they say the patient is in shock, and you can easily say we have a situation where they say the patient not in shock, the patient has got anaphylaxis from a certain drug, but actually the patient is in septic shock. So that's very important. And then blood culture collection, the volumes are very important. So for every ml of blood, there's an increase in 3% of identification. Because remember, the bags are floating in the blood. Sometimes they're not, the density is low. So therefore, you need a lot of blood to detect it. And aseptic technique. So we want the skin to be properly prepared, and then blood taken accordingly. So if the aseptic techniques are not being followed, you have very high contamination rates. But we're aiming for less than 3%. So incubation, again, has to be done at an appropriate time, because delays means some bags stop being viable. So that's important. Now, lab transportation, you can imagine sometimes in the night, if the transport is not well scheduled, you might find that overnight the blood never left the ward, and therefore viability of the organisms goes down. The other thing that happens on the ward sometimes, people collect blood cultures, and the system is not very good. Maybe the porter doesn't come to collect the blood because nobody's aware blood culture has been collected. So in the ward itself, there may be issues which need to be dealt with. So really, the challenges at a pre-analytical phase is about the collection of blood culture, correct volumes, transportation, and incubation. So we have to make sure the service runs 24 hours for the blood to be collected continuously. So at the analytical phase, we have other challenges that we need to look at. So traditionally, with blood cultures, it's a positive blood culture. The next step is a gram step, looking under the microscope. Is it gram positive, gram negative? That is a standard which has been there for 100 years. Following is you try to grow the organism on a plate. And that takes 18 hours overnight. And then after you've got growth, you want to identify the organism and do sensitivity. That might take also another 18 hours. So we're talking about close to 2 days. There are some organisms where you could do direct identification from blood culture, but that again, that will be 18 hours. So it's a long process. But in terms of identification, you can actually cut down on the time of identification. So at UHCW, we have what we call sepsis typer. With that system, we can take blood from a positive bottle and identify the organism quite early. So we can have an ID within 2 hours. So that cuts out 16 hours, which is actually a big improvement. And so we are able to actually say this organism is this in about 2 hours, and we don't wait for overnight. So that's a big improvement, and we are then able to preliminary sort out either escalation, de-escalation, or stop antibiotics while we're waiting for sensitivities. So in actual sense, the system, you could get your answer in 20 minutes. But that is assuming the technician is just following one bottle. It's positive, then they start doing that. But as we know, the diagnostic labs are not like that. So probably we're going to have a batch of positive catches and then run the test. So that's why we're saying under 2 hours you can have your identification. Now, the other area of delay is sensitivities. So with sensitivities, again, we need to grow the organism on a plate to do the sensitivities. So that takes, again, 18 hours. So with that, it means 18 hours to have growth and then determine what's the right sensitivities to do. That's another 18 hours. So two days. But we can improve on that. We use a system called RUST at UHCW. And with that system, we are able to get sensitivities within 11.4 hours from a positive blood culture, because we can do the sensitivities much earlier. We cut out the time, the 18 hours time. So actually, compared with the traditional way, where it's about 31.9 hours from positive culture to sensitivities, we are getting that within 11 hours. So that's, again, that's a big improvement. So the advantages of having a quick ID and sensitivities is that targeted therapy can be done much earlier, and we can quickly de-escalate or escalate treatment. And in terms of infection control purposes, we are able to identify multi-resistant organisms much earlier. And therefore the infection processes can begin much earlier, which means maybe less patients are exposed to such highly resistant organisms. And as we are very aware, nowadays we understand much more about the gut. The gut is very important, and antibiotics destroy the gut. And the more we are more precise with our treatment, the more the patient's gut is protected, the microbiome is protected. Also, what we find is certain, after we get a gram, certain organisms, we have a hunch that these might be contaminants. So we can wait not to phone them out, because within maybe 2 hours we have an ID. So that saves us time as well, because we are not dealing with things which are not important. And then we can just phone them to say, if patient is not septic, let's stop antibiotics. So that actually is very helpful. So a conclusion on current culture-based improvements. At the moment, culture itself is the limiting factor. Okay. Now with this, we've improved on identification. We have improved on sensitivities, but the culture part, we have not, okay? Because the systems are not out there to give us that. People are working on that, but we are still relying on the traditional way of doing things. So the area where a lot of work needs to be done is on the blood culture aspect. And that aspect is actually, can we identify what is in that blood? That identification will be just, for instance, PCR. And we'll be able to know, okay, there's E. coli or there's Staph aureus in that blood culture. But we can't do sensitivities because we have not grown it. So we have to combine the traditional way of doing it and the molecular diagnostics. But the problem with the molecular, it's not a problem, but challenges with molecular diagnostics that you need to have primers or things which you are trying to detect. So you have to have an idea what things might be in that blood. So there will be limitations because you may not have everything in the PCR. But if you did have a positive PCR and you know what organism it is, you can fairly target the treatment. Although for certain organisms the sensitivities are fairly predictable. So if I was told it's a Staph aureus, I know the sensitivities are very predictable. I can change treatment with confidence. But certain organisms, if I was told it's E. coli or Klebsiella, I cannot with confidence know which will be the best antibiotic. So I'll still be requiring that sensitivities. So there are a lot of studies people are doing trying to see what the molecular diagnostics can do. And somebody looked at a lot of studies, 19 studies in neonates, because neonates is very difficult to diagnose sepsis, because anything upsets the baby and you don't know whether it's infection or whether it's feeding or whether it's anything. So here is a group of patients who get a lot of antibiotics. Traditionally, what we do is every 24 hours we release a preliminary report to say there's no growth, so 24 hours, 48 hours. And then the doctors have the confidence to stop antibiotics, depending on how they assess the baby. Sometimes, because these systems are not 100% proof. So blood culture is not 100% sensitive. Actually, we miss a lot of cases where patient has sepsis, but because the blood culture volumes are not right, and because the incubation time was not right, the organism maybe died, so we get a negative culture. So having a negative blood culture does not mean the patient is not septic, okay? Because it's not 100% sensitive. But it's helpful for the pediatricians or neonatologists to make a decision where they are not sure it is sepsis or something else. So every 24 hours, 48 hours, 72 hours, a report is produced. No growth, no growth, no growth. But they have to actually risk assess whether to stop antibiotics or not. So with a PCR would be very useful, especially in neonates, because you can detect whether there's some fragment of bacteria there, whether it's dead or not, you're still able to find that. So looking at the studies, it looks like 98% sensitivity to detect something in blood pressure using 16S PCR. So it is quite good, and very specific as well. So it is something that can be done. The only constraint is money, because you could have systems like that at the point of care in A&E. They would have to put in some of the blood in the machine and some of the blood in the bottles. But it requires investment. So that's where I think we are failing really. So post-analytical phase. Okay. The post-analytical phase, as far as microbiologists are concerned, is transmission of that information to the clinician. And it can take, it depends on hospitals, how good they are in terms of answering the phone, what setup is there. So you can try to phone the ward to give them the result. Nobody picks up the phone, okay? So you can't spend 1 hour trying to get somebody to pick up the phone. And I've actually gone to a phone, 1 hour, nobody picks. I go and I leave the phone on the side, go to the wards, the phone is calling, people are chatting there. Okay? And you say, can you pick up the phone? And they pick up, it's me. I need to go there and see. Okay? So they seem to be deaf to the phones. If they're sitting there and nobody is picking up the phone. So it's a huge challenge. There are other trusts which are very good in the sense that they have systems where microbiologists will put the result in there, type what needs to be done, and there's a central, like a control on nerve center, whatever. They are the ones who now chase up the doctor to say, can you look at the result? There's a result on the system, okay? And then it's done that way. But otherwise, imagine it's 1 hour not getting through. You go on the ward, nobody wants to take responsibility. It's not my patient, it's not my patient. So that can be 2-3 hours before action is done. So that's the problem. Electronic systems, if doctors could be notified immediately that there's a result for you, and then look at it, that would be good. Now, again, with the telephone, there's miscommunication. So it's not unusual to find that what you've said, when you look at what they've documented, is completely different. Patient is on the wrong thing. The investigation that we have recommended is not there. So we have to type everything on the report, what we want and what we've said, etc. Make sure that it goes through. So it's always, I understand people get exhausted. And this might be the reason why they become phone deaf. They don't know, because once you pick up a phone in the hospital, that could be a job for you. You know? Yeah. And it could be a relative who wants to speak and speak and speak. You've got many jobs. Yeah. Okay, so now that's our challenge post-analytical phase. So I've gone through what the challenges are in the pre-analytical phase. Basically, the logistics of taking that blood, identifying septic patients as early as possible so that they can be started on antibiotics, filling the bottles correctly so that the detection should be acceptable, and keeping the bottles at the right temperature. Because the systems we use detect growth by certain chemicals. Now, there are certain organisms which, if you keep them, say, 1 hour, 2 hours, without putting them in incubation, the machine will not detect that there's growth. So Pseudomonas, for instance, the machine will not detect. So we need to do that in good time. And then the analytical phase is where we are working at good progress, but we need investment in molecular diagnostics to go hand in hand with the traditional methods. And then the post-analytical is trying to get the clinicians and the teams to act on the results in a timely manner, and also to make sure that there's good communication between the laboratory and the teams. So with that, I come to the end of my talk. Thank you very much.